Good evening and welcome, everyone. I'm Susan Fernbach. I'm the Director of Community Engagement and Outreach for the Department of Molecular and Human Genetics at Baylor College of Medicine and Texas Children's Hospital in Houston. And welcome to the first webinar of this Evenings with Genetics series for 2021. And this actually is the beginning of the 15th year of this seminar series. So I'm really excited that we can start this with the TANGO2 story. This is a really special evening. I guess I ask that everyone mute your devices. It looks like everyone has. We ask that you write your questions into the chat box at the bottom of your screen. We are recording the webinar and we will be able to put that on our website, and I put that into the chat as well. It's the bcm.edu/evening genetics, and we'll be putting the recording on that website. We have 3 speakers this evening, and I'm really excited to tell you about them. The 2 physician speakers, Dr. Seema Lalani and Dr. Christina Miyake, are members of the team that first described the TANGO2 disorder in 2016. And since then, they have devoted great effort to understanding this condition. So our first speaker tonight will be Dr. Seema Lalani. She's a professor in the Department of Molecular and Human Genetics at Baylor College of Medicine. She is board certified in pediatrics, in clinical genetics, in clinical cytogenetics, and in molecular genetics. Dr. Lalani is focused on identifying the genetic basis of cardiovascular and neurodevelopmental disorders in children, and she sees patients and their families in the genetics clinic at Texas Children's Hospital. Dr. Lalani also serves on the board of directors of the TANGO2 Research Foundation. And our second speaker will be Dr. Christina Miyake, and she's an associate professor in the Department of Pediatrics section of pediatric-cardiology, and she's an associate professor in the Department of Molecular Physiology and Biophysics at Baylor College of Medicine. She's a member of the Arrhythmia and Pacing Service and the Cardiovascular Genetics Clinic at Texas Children's Hospital. Dr. Miyake specializes in the care of pediatric patients and families with inherited cardiac arrhythmia disorders. And she serves on the scientific advisory board of the TANGO2 Foundation. And then our third speaker will be Mrs. Laura Moore. And Laura is the mother of 3 children, one of whom has the TANGO2 condition. She and her husband, Blake, are both active volunteers with the TANGO2 Research Foundation. She will share their story and her insights tonight. So please give a warm welcome from your homes to our speakers, and Dr. Lalani will take it away. I'll turn it over to her.
Thank you, Susan, for that introduction. Let me share my slides. Hope everyone can see this and hear me well. All right. Thank you again, Susan, and it's a great pleasure to be here today. And again, I'm really honored. I will be talking about TANGO2 with my colleague, Christina Miyake, and dear parent, Laura Moore. She will talk about her journey with this disorder. All right, so these are the beautiful faces of children who have TANGO2 disease, and they have similar stories. My journey with TANGO2 started with this young child, Sammy, and I'll tell you a little bit about him. So I started seeing Sammy around 2007, 2008. And at that time, the parents were concerned that ever since he started to walk, he had unsteady gait. So he had motor incoordination, he had a slurring of speech. Later on, he developed seizures. And we really tried everything to try and find a diagnosis for him, but we couldn't. In 2000, when he was 8 years old, he got admitted to the hospital, and he was very sick at that time. And we found out that he had cardiac arrhythmia at that time. His muscle enzyme was elevated. He had hypothyroidism. And again, we did not know how to put everything together. And um, it wasn't until 2016 when we were able to give him a diagnosis. So he was part of this study, which was a huge effort from Baylor. We had 12 families, including Sammy, and we described children who had similar problems, just like Sammy. And with us, there were German investigators who published their story of 3 families, again presenting very similarly. So, how do we diagnose this condition? So, in our study and even in the other studies, what happened was exome sequencing was able to help in putting the phenotype of these children together. So what we were seeing is that these children were coming in metabolic crisis. So what I mean with that is that they get very sick very suddenly, and that can happen with infection, a febrile illness, fasting, or vomiting, not being able to keep anything down. And then quickly they spiral into this metabolic crisis where they have difficulty walking and they are brought to the emergency room. We were seeing that these children were from all ethnicities. So it wasn't just a particular population that was getting affected. We saw Hispanic ethnicity children affected. We saw Europeans. We saw children from Middle Eastern side. And also African American. And so we quickly realized that all these children from different ethnic groups were presenting very similarly. Classic presentation during this metabolic crisis was this muscle breakdown called rhabdomyolysis and susceptibility to life-threatening cardiac arrhythmia. This is how they present to the ER. So as I said, they are not eating, they are vomiting. They develop significant muscle weakness to the extent that they have difficulty walking. In medical terms, they can present with ataxia. They have mental status change, so they are disoriented. They can be comatose. And when they are tested, they are found to have low sugar level, slightly elevated ammonia, and elevated lactate level. And parents have seen dark urine during these episodes. And when their CPK, which is a muscle enzyme, is measured, it is very high. And these children during this crisis episode are at a very high risk of developing life-threatening cardiac arrhythmia. And unfortunately, we have lost some children with TANGO2 disorder to this crisis. So that's why it is extremely important that we make this diagnosis earlier in children before they present this acutely ill. We've also seen that after they have had this episode, this metabolic crisis, they can have developmental regression. So a child who's walking may lose the ability to walk and either may not walk independently after the crisis or take months or years to become ambulatory again. So needless to say, these are really, really sick children, and these are really serious episodes, all because of TANGO2. So the main goal for today's talk is to save lives of these children by diagnosing them earlier. So before they have their metabolic crisis, they have several signs and symptoms that I feel that as healthcare providers, we should be able to see and at least suspect TANGO2 disorder. So we've seen that almost all children have developmental delays. So it could be a child like Sammy who, as he's walking, he's not walking well, he's tripping, he's falling. So motor delays is one. Intellectual disability can be seen. Abnormal gait, and I'll show you some more videos of what that gait looks like. Poor coordination, slurred speech. And parents talk about this variable tone, either low muscle tone or tightness in some parts of the body. So the legs can be tight. They may not know the term dystonia, but this actually indicates the head tilt that the parents have reported multiple times that they are seeing in their children. We don't understand the mechanism of why the muscle tone abnormality is there, but it's related. So this is a neuromuscular disease, and all these things could be connected. We also have found that children have low functioning thyroid or hypothyroidism. Also, exotropia or lazy eye is something that we have frequently seen. Seizures is also something that many children have, and there are different kinds of seizures. So it can be generalized tonic-clonic, it can be a focal seizure, and sometimes seizures can be difficult to control. Also, there are some episodes that look like seizure, but actually they may have these sudden drop of tone that parents have seen in their children, and I'll show you example of that as well. So not all episodes that look like seizure are seizures in these children. Very interestingly, parents talk about these intermittent random episodes that they've seen in their children. And again, we have poor explanation for why these happen. So extreme fatigue just comes out of nowhere, loss of muscle control, weakness, and then drooling, which is intermittent. So it comes and goes, swallowing issues, which also comes and goes, and then dystonia or head tilt that they have seen, and slurred speech. So here I wanted to show you some examples. I think if we see them, we'll remember them better. So I'm very grateful to the parents who've shared these videos with me. And the purpose of this is, how can we diagnose TANGO2 earlier than their first metabolic crisis? So here is a child who you will see the gait and the posturing. So she is trying to draw, and you can see that this tilt of her body starts, which is head tilt, but also involved the trunk. And then it is to an extent that she's unable to continue walking, and she starts to crawl. Nothing stops children, by the way. So they want to do what they want to do. So here you can see again that yet she gets another episode of dystonia here. This is another child, and very similarly to the first one, you can start to see the head tilt that she has, and then you can see the half of her body is going to turn. Again, just starts, and no explanation of why these come and go. Here is a child who had a surgical procedure a day before, and you can appreciate the walking abnormality, that the gait problem that he's experiencing the next day. So this unsteadiness, it wasn't like that. It's not usually the way he walks. This is his sister, who has a diagnosis of seizures, but she used to have these episodes when she would just drop her head down, and it remained unclear whether this was seizure or just loss of body tone. A number of children are known to have this. Then you'll see her again. She is sitting, and then she will lose her balance, and then she gets up. extreme fatigue. So here is Ryan. You can see that he seems very tired. So these episodes come out of nowhere, according to his mother, and they are instantaneous. They just come, and then accompanied by drooling and garbled speech, dizziness, and he probably would have this in clusters, and then come back to his baseline by day 5 or so. Nobody knows how they come, why they come. There are no known triggers. So a lot of families also report these kind of episodes. Oh, sorry. Sorry, let me go back to that. All right, we talked about Ryan. And here I wanted to show you some of the walking and running abilities of these children. So here, as I mentioned, the first crisis can really affect your motor abilities. Some children really who are ambulatory lost their ability to walk independently. Some children became ataxic. And you see a variety. I'll also show you some children who are able to run. This is a child, and looking at the gait, the neurologist, I showed it to thinks this is ataxia. So you can see and how happy she is that she conquered the steps. This is a child, and she is the child with the helmet who was losing her balance when she was young, and see that she improved in her motor skills and she's able to run. And here is Ryan again. So you saw his extreme fatigue episode, and you can see that he's also capable of running. And here is Sammy. So Sammy, I told you, loved football, and this is Sammy. He's going for a touchdown, surrounded by his teammates who really care for him. And so this is also one manifestation of TANGO2, like you are able to run like that, but there is a variability, as I showed you. Then the other thing I wanted to show you was the speech that you can actually, so with the speech, you can sometimes also tell or think about TANGO2 because it's slurred, and in combination with other motor problems that they are having, this can easily be suspected. Let's see if I can advance the slide. Yes.
Fun that makes me the happiest to cheer my teammate on.
So here is Ryan talking about Special Olympics. He's participated in Special Olympics and is cheering his teammates here. So let's listen to that again. So notice the slurred speech.
Fun that makes me the happiest to cheer my teammate on. Let's go teammates, because you guys, you can do it.
So you notice that she has difficulty with speech. She's also a little bit nasal. And then the last one.
What do you see? There's a bit in the yellow box.
Look at it up too.
Yeah, we can't touch that one though.
Ouch.
It'll give you owies.
Uh-oh.
Wow, what would we do without our mom? She understood everything what he was saying. So again, articulation problems you can appreciate. So what I hope that these videos helped give you an idea of the spectrum and the problems that the children can have at TANGO2. And so just having a high suspicion for when we see these patients in clinic. So what do we do for these children? So cardiology referral, very important. And Christina will talk more about the cardiac manifestations of TANGO2. we send them to endocrinology service because of the risk of hypothyroidism. And again, they should have a neurologist to manage their epilepsy. Therapies, physical, occupational, speech therapies, we recommend, and we would refer them to developmental pediatrician for a timely assessment of the development. Very, very important is that we tell them to avoid fasting, because if we know one thing that can save lives is at least not to go into metabolic crisis. So if we know that fasting can put you in metabolic crisis, we do our best to avoid this. So many of our children have good meals. They snack multiple times throughout the day. And interestingly, many younger children have figured out that they feel better by snacking more. And so naturally they have been doing this for a long time. We know that ketogenic diet can precipitate severe metabolic crisis. So for epilepsy, if they're put on ketogenic diet, that can be devastating. And an emergency plan should be in place to initiate steps so that we can prevent life-threatening rhabdomyolysis episodes and cardiac arrhythmias. And we have on the TANGO2 Research Foundation website, we have placed an emergency letter for anyone to use that actually delineates the labs that are needed, the type of intervention that the child would be needing at that time. Main thing is we don't want children to be waiting in the ER and having cardiac arrhythmia. They have to be triaged fast, because if they have not eaten and they are having vomiting and they are dehydrated, this can be catastrophic. So now let's shift gears and then talk about the genetics of TANGO2. So what causes this disorder? So we all know that there are 23 pairs of chromosomes. TANGO2 gene is on chromosome 22. And we have two chromosome 22, and therefore we have 2 copies of TANGO2 gene. All of us have this. So all of us have 2 copies of TANGO2 gene. But it is when these copies are not working well and they're altered, then you get the TANGO2 disorder. So we say that TANGO2 is a recessive condition. And I'll explain this here. So this is a healthy person who has both copies of TANGO2 working well. This is a parent of a child who has 1 copy altered of TANGO2, the other one works fine. So health-wise, they wouldn't have any problems. They would be considered healthy carrier parent. But it is when a child inherits 1 altered copy from mom and 1 altered copy from dad, that's when the problem happens. So both TANGO2 genes need to be altered for the disease to happen. And for families like these, when parents are carriers of TANGO2 alteration, then there is a 25% chance of having an affected child. So this is, so that's why it is important to make these diagnoses earlier, and so that appropriate counseling can be provided to the families. What are the types of changes that affect the TANGO2 gene? So, and I get asked this question a lot in clinic. So I tell my families that this is how the gene can be affected. So if you imagine that our genetic code is like a book, and we have 20,000 pages in this book, each page is a gene. And so if you look at this page, and let's suppose this is a page that depicts TANGO2. So you could have a missing paragraph part of TANGO2 page, and that is called deletion of TANGO2. We have seen that many of our European families actually have this kind of change of their TANGO2 gene, and we call it exon 3 to 9 deletion. This is a gene and it has 9 exons, and the red bar indicates the size of the deletion. So many of our families have missing paragraph, and then many of our families also have just misspelling of this page. So they may not have deletion, everything seems intact, but they could have one area which is misspelled, one word which is misspelled, and that is enough to render this page non-functional. So one example is the Hispanic mutation we see, which is G154R. Sammy was found to have 2 copies of the same mutation, and that was enough to give him all the problems that he had. So it can be both. And how do you confirm the diagnosis of TANGO2? So you could, if you are sure that the child has presented with rhabdomyolysis and heart arrhythmia and has developmental delay, there is no other diagnosis except TANGO2, then you can just ask for TANGO2 testing. And again, you should pick a test that checks for both deletion and misspelling testing of TANGO2. You could pick a gene panel, which means that you are not too sure, but you want to at least cast a net that covers other genes as well as TANGO2. So you could pick a seizure panel or a rhabdomyolysis panel, depending on what the child presented with, or a low glucose panel. And you have to make sure that the labs that offer these panels have TANGO2 covered in their panel. So that is another way. And then exome sequencing is the most widely done test that we found in our study, where children were diagnosed with exome sequencing as well as the microarray analysis. What about children with 22q11 deletion syndrome? So this deletion syndrome is on chromosome 22. It's quite common, relatively more common. Children have DiGeorge syndrome. The question is, it is the same place where TANGO2 is. So what about those children? Do they have TANGO2? So no, actually the answer is that most children with DiGeorge syndrome do not have TANGO2 disease because one chromosome is affected in them. So the deletion does include TANGO2, but it has a number of other genes around it that gives them the DiGeorge syndrome diagnosis. And these children mainly have very different problems. They have heart defect, they have immune deficiency, they have cleft palate, they have very distinct face, which our kids do not have. The only way this child will have TANGO2 as well is if the second copy of TANGO2 is affected by either a deletion or a misspelling. And in that case, a child who has DiGeorge syndrome, you will see that this child is also having muscle breakdown problem and heart arrhythmia problem, which are not seen in DiGeorge syndrome. This happens very rarely though. So, but just to keep an eye, because DiGeorge syndrome is more common. So TANGO2 gene must have a very important function. And there are so many research questions. Why the muscle breakdown? Why the heart arrhythmia? Why seizures? Why hypothyroidism? Do vitamins help in preventing metabolic crisis in these patients? Why do some children look like they have mitochondrial disorder? And then what is the function of TANGO2? So in 2017, a number of families came together and established TANGO2 Research Foundation. And now we support over 100 families that are international. So more and more children are being diagnosed. And last year in 2019, summer of 2019, we were able to bring some of these families to Houston, and we learned a lot from each other. We talked about what we knew, which was not much. And there is just so much to learn about was the problems and the basis, the pathophysiology of why these things happen. The conference was a success. It was supported by PCORI. The other thing that I wanted to mention is that the TANGO2 Research Foundation has just in this year has supported multiple investigators internationally. So from USA, Canada, Germany, and France to try and understand the basic mechanism of TANGO2. And you can go to their website to get a complete narrative of what these investigators are trying to do and trying to understand, and just know how we can save lives of these children. Two of these, actually 3 of these awardees had 2 papers published, which was recent, and you are welcome to go to the podcast to get a brief summary of their findings. So we have currently a natural history study going on at Baylor College of Medicine, led by Christina. And what we are doing is we are trying to find what saves children by talking to families, by looking at their medical records. If a child comes out of a crisis, what was done for that child? What medication was used so that it was a success story? So all these things can be achieved by doing a study like this. And so if you are not part of the study and want to be part of it, please contact our study group. And here is the contact information, and also you can get it through the foundation's website. I also wanted to mention Dr. Lindsay Burridge and Dr. Nali, who are looking at the TANGO2 mouse model, again, to try and understand the mechanism of these metabolic crises. So these are just, I wanted to end here with faces of our children. This is from the conference. Thank you again for your time. I am going to pass it on to Christina Miyake now. Let's stop sharing.
Okay, hopefully everybody can hear me. Thank you everybody for coming and participating tonight. So I'm Christina, and along with Seema and Laura, my section of the talk is going to be focused a little bit more on the cardiac manifestations. So I first met my first family with TANGO2 actually in 2014, probably at around the same time that Dr. Lalani was looking for answers, so was I. And it was really an amazing, time to come together with her and to discover this disease for so many children. Since that time, since my first family, I've had the honor of meeting so many more children and families. And while some of them are followed by me here in Houston, many of them I've never met in person, but it's probably you, their families, and their stories that are so important and have allowed us to learn about TANGO2 and are really what I'm going to be sharing with you tonight. It's from their stories. And it's really what's going to allow us to recognize more about this disease, learn how to treat it, and ultimately to find the cure. So Seema already talked about and mentioned the natural history study. The natural history of disease refers to the progression of disease over time in an individual in the absence of intervention. And that really describes what we're trying to do in TANGO2 right now, because we don't know the right intervention for this disease. So as you listen to tonight's talk, I want to mention that the data and the information really is coming from this study. And it's driving the ongoing research. Just as an example of how important this is and how we're using the information. When we first learned about TANGO2, many of the patients that we were following were between the ages of 4 and early teenagers. We didn't know that it could affect infants, and we didn't look for that in infants. But it was Lindsay Messersmith who, after talking to her, sharing her story about Jackson, we realized that TANGO2 can indeed affect infants very young and very severely. And thanks to her, we've been able to spread that information and help others, I think, recognize it earlier. So these are the stories, and these are the things that are so important to us as physicians to learn, because you as parents know more than us in many ways, because you're living with this with your children, and their stories can really help us. So let's move on. So, based on the natural history study and my own experiences taking care of children, many in Houston, actually, and many across the world by phone. I wanted to share with you 2 areas that I felt were of high priority. It's important to know that this is really my perspective. As Seema already discussed, there's so many different areas that TANGO2 affects in the body, including the heart, the brain, the thyroid, muscles. And if you take, and so what poses kind of a risk for TANGO2 children may be different from a perspective from one individual or one physician. So really this is mine, but it's what I've learned from following so many families. And I wanted to prioritize these 2 areas because I felt they could make the most significant impact, at least right now. And so the 2 priority observations that I've made over time is that these metabolic crises are setbacks. They not only seem to cause regression of development, but in my mind, they seem to alter potentially the baseline status. In other words, a crisis may affect the future trajectory of the child, how much and how fast the children will develop subsequently. So I worry. As an example, I worry that a child that's developing okay has a severe crisis before they even walk. And I worry that that may affect that child's ability to even walk in the future. And so to me, it's important that we learn how to recognize and how to prevent these crises in order to make sure that we don't cause this potential regression or setback. The other area that I wanted to prioritize in today's talk are the cardiac abnormalities that Seema already mentioned can be life-threatening. In my mind, the cardiac abnormalities, at least as far as we know to this point, are the major risk to life. And so I wanted to make sure that you guys could recognize it, know what to do, and empower you as parents to be able to help prevent this, or if it happens, to know what potentially you can do. So as a clinician scientist, data is always going to be the driver and the utmost importance to me. I want to be very clear that what I'm sharing from you is really just information that I've gathered. And again, with more data comes more information, and this might change. So this is what we have right now. I have 42 participants that have enrolled in the study, 38 of whom have given us full information, and they come from 31 families. 63% are male. That doesn't mean that it predominates at male. It just may be who signed up. 63% are Caucasian in this study. What's interesting is you can see that the current ages of the children really vary. What really is encouraging to me is that we have some that are much older in adulthood, with our oldest patient being currently 29 years. The person's almost 30 years old. The current average age of participants is about 10 and a half. So the average age of diagnosis is 8 years, but hopefully with Seema's talk and with more people recognizing the disease earlier, this age is going to become much earlier. There's a total of 61% of the children in this study have had a crisis, with the average age of crisis being about 4 years, 4.5 years. The range is very young, up to even starting in the teenage years. So how do you prevent crisis? I think the most important is recognizing the triggers. And I want to clarify that this metabolic crisis is different than these acute intermittent episodes that Dr. Lalani not only described, but she showed you videos. Crisis really involves specific lab changes, this rhabdomyolysis, elevated CK. And so this is a very particular, much more severe episodes that come, and they tend to have specific triggers. These triggers are often colds. They can be fevers. They can be something as minor as a stomach bug. It can be, like Dr. Lalani mentioned, prolonged fasting, the initiation of ketogenic diet, or being asked to be NPO, which means to not eat prior to a procedure or surgery. I think that is one of those are big triggers. In general, this fasting, not eating for prolonged periods of time, can be for any reason. So a child in particular that's picky, who doesn't eat, and it's kind of sustained over several days, even though they're eating, you got to think about that as potential reasons or periods why they might have more of these intermittent episodes, but ultimately long-term with just a little something can kind of end up in a crisis. The other thing that we've learned through the study is that dental abscesses can also be a trigger. So whether that is because the child's not eating, or because it's an infection or the dental abscess itself is not clear. But we know that even if your child's not sick, look for other signs, look in the mouth, look for other areas that might be infected, as this has been a trigger for other crises. The other one that I have a question, because it has been a trigger, it's much more rare. It tends heat, that means just the hot weather, not baths, but hot weather tends to really definitely cause fatigue, more of these acute episodes, but it has been a trigger in at least one child. So we live in Texas, obviously it's very hot here. I do recommend, trying to keep cool and having things to protect you from the weather, but I haven't seen crises as often, for example, in children in Texas, and that might be something we might want to look at in terms of the weather. We've got many children in the United Arab Emirates, for example. So what can you do? Be very vigilant as a parent around these illnesses. In particular, watch your child's nutritional intake. For me and for my children, or my patients, I always recommend that if you see any signs of illness, go ahead and start supplementing. Thing that I recommend is a liquid supplement like the cans of Ensure, Boost, Pediasure, importantly, not Pedialyte, not the liquid kind of just the like the Gatorade, but more Pediasure. It's got more nutrients, I think. If you can get them to take that, I think that might help, at least in our preliminary data from the study. If you have a G-tube, run it through the G-tube. If you don't have a G-tube, feed it in small amounts, small spoonfuls throughout the day. Be vigilant, be on top of them, because this might help prevent them from developing that crisis. If you do have an illness, I recommend getting them checked out in the emergency room, because you can get the labs, you can get the EKG. Remember that it's not always the beginning of the illness. It could be during the illness. It could be even after recovery of the illness. That when these crises occur. So pay attention to your child. In particular, again, I think it has to do with feeding. Other situations that can result in these, I call them spells. These are these acute intermittent episodes where the child becomes fatigued, has these drop attacks. These are times in which parents have kind of described, and as we've gone through the study, these are some periods that put them at higher risk. Visiting friends' house. Sorry, let me, my dog is, I'm really sorry, is squeaking. So car rides, trips, visiting houses, holidays, these are times in which you tend to be busier. You might not be paying as much attention. The children may not be getting as many snacks, or the meals may be different. The timing of the meals may be different. And these are times in which you may want to just pay a little bit more attention and make sure your child's having frequent snacks. As Dr. Lalani mentioned, children that tend to snack more often do tend to be better. Other times, school. So if your child goes to school and is left to eating at school, make sure you know what they're eating and if they're eating or not. A food diary can be very helpful, making sure you communicate with your teachers, children's, and knowing whether or not they're eating and having a plan if they're not. A snack basket there with foods they like to offer, or if they're not eating at all, to communicate that to you could be really important. The other time period in which it's coming out in our study is this transition from the infancy, when they start sleeping through the night. It seems to be this period in which I begin to start seeing the symptoms. And I wonder whether we can delay the progression of these symptoms if we start to work a little bit differently in terms of the transition. So we're all very excited when our infants start sleeping through the night, but it seems to be that maybe that longer time period, the fasting, the baby goes to bed at 10 p.m., let's say, and doesn't get up until 7 or 8 in the morning, that longer period, maybe it means getting up a little bit earlier, making sure there's a feed. Dr. Lalani also talked about the emergency plan. I also want to mention gene reviews. So these are 2 areas that are on the web. They are written documents. I would not only have notice of them. I wouldn't just tell your doctor, hey, this is the emergency plan, or go to gene reviews, because as a physician, knowing how hectic it can be, We don't always have the time to do what we really would like to do for your child. So what I would recommend is downloading this, having a copy, and having it in hand, putting it in your car, having it in a place that you can just hand to your doctor if you ever get in this situation, because the information is there. If it's there, it's much easier to follow. So how do you know that your child's in crisis? Don't just rely on your physician. Consider actually getting those results and knowing yourself what your child's baseline is and whether or not these numbers were elevated. To me, I know there's different numbers. To me, these are probably the most important for telling me that your child's in a crisis. The CK or CPK is always elevated. The sugar or the glucose is generally low, but it may not be. We've had kids in crisis with normal sugars. The liver enzymes are typically elevated. The ECG is always abnormal in a crisis. And the sign of it is a marker called the QTC, which will be prolonged or longer than is typical. And I'll go over that. So what do you do? Again, you can direct your doctor. So let's say your child does have signs of crisis. You know, that child needs to be admitted to the hospital. And if you're in crisis, ideally one that has ECMO. ECMO is a machine, it's a bypass machine. I show you a picture of it below. It takes over the heart and lungs and temporarily, particularly if there's a problem with heart rhythm or heart failure, but it's a last ditch effort and it can definitely save lives, but only certain centers have this ability to utilize it. Importantly, IV fluids are going to be the first mainstay of treatment when your child is admitted. And it is important to address that sugar quickly and start administering fluids, particularly if dehydrated. You want to wash out the CK, the rhabdomyolysis. You want to wash those the muscle enzymes out of the body so that they don't accumulate in the kidney. But IV fluids are not always the answer to preventing the cardiac rhythms. For sure, they are not going to prevent the rhythms. Many physicians, when we think about these type of crises, we think, oh, if we treat the sugars, we're going to be okay. We're giving nutrition. But this isn't the type of nutrition I think that actually don't prevent crises, because we've had several kids develop it. The IV rate also needs to be carefully monitored, because if your child is in heart failure, you don't want to give really rapid IV fluid. So in terms of heart failure, that's very important. It's on your emergency plan. It says to check an echocardiogram, and that's in addition. So that is looking for signs of heart failure, and this can not only come and go, but it isn't always there at each hospitalization. And it's important to look because it can develop over time. A normal echocardiogram in the beginning does not mean that heart failure doesn't develop 2 or 3 days later. I also really want to, for my patients, I focus on the nutrition. And again, this may or may not be the right answer, but it seems to be, to me, the children who are made NPO, meaning that they are admitted, they're put on IV fluids, but not given any nutrition, do seem to do worse. It doesn't seem to prevent the crises. So for my children, if they are eating, if they're taking anything at all, if I was a parent, I'd ask if you can feed them at the bedside, even if it's spoonfuls of, and ideally, again, I mentioned the Boost, the Ensure, the Pediasure, Nutrin, anything like that, where they can take spoonfuls if they can tolerate it, is helpful. There are other forms of nutrition that can be given IV. We don't normally do it in children early, but it is something I have used in the past. It's something to consider talking to your physicians about. So let me talk about the heart in particular and what you need to know as a parent. I think of the heart in 2 different ways. There's kind of the heart, the walls of the heart and how the heart pumps, and the electrical system of the heart rhythm. And in my mind, I kind of talk about it like a house. Each of these systems are kind of independent in a way in how you look at them. So in other words, you can have an electrician look at your wiring of your house, but they may not be able to tell you that the back wall is completely about to crumble. Same way, your house can be completely normal and fine on the outside, but the electrical system has gone haywire. And so you need to look at the heart in 2 different ways. The electrical system, which is the most important, is done through an EKG. It looks at the heart rhythm. If you recognize this machine, it is hooked up and you've got lots of different stickies on the chest. It's relatively quick, but this is what you want to check for QTC prolongation. The walls of the heart, or the function or how the heart pumps, is assessed by echocardiogram. It's an ultrasound. It's a much longer test. If you remember it, it kind of has this big machine, and you've got a probe on your child's chest with jelly, and you're going to look at the heart structure and how the heart pumps. So the heart, when not in crisis, is normal, and that's important. So even if you go to the doctor, you should follow the cardiologist so they know your child. Your heart, if your child's normal running around, the heart, the echo and the EKG should be rock solid normal. The crisis, it's only in crisis that we see this heart problems, and the QTC is always prolonged. The heart failure is less common, but it can occur at any time during crises, and both issues can lead to death. So I want to empower you. The EKG, if you look at it, this is the QTC. There are numbers that are printed on each EKG. This is the number that you want to pay attention to, not the QT, but the QTC. It's got it corrected. So it's the second number. If they're separated, you're looking for the QTC. This number here for this child is 491. It's abnormally long. A normal is less than 450. So that's your marker. If it's over 450, it's abnormal. And that should be an admission concerning for a crisis. Importantly, you do want to get your baseline EKG. Some children can have longer QTCs even when well, so you want to know what your child's baseline is. If the QTC is prolonged, then there is a risk for heart rhythm problems. It's particularly risky if that number gets over 500. So you don't want to check the EKG just once. You want to check it multiple times during the admission to see, because it will change and it will get better as the crisis is resolving. So again, the arrhythmias can develop anytime. Your child can be looking better, and if that QTC is long, they can still develop a life-threatening heart rhythm problem. If you're at the bedside, your child should always be on a monitor at all times. They shouldn't be hooked up intermittently. They should be on at all times if they're in a crisis. This is what it looks like. You're going to see different colors. In general, the heart rhythm and heart rate is generally in green, and each of these spikes is a heartbeat. What we're looking for are changes. If each of these spikes is our normal heartbeat, you're looking for these weird abnormal beats that look different. And these are called PVCs. They are a warning sign that something bad could potentially happen. They usually begin as single beats. They may become more. These are called couplets if you have C2 or more in a row. And if you see 3 or more in a row, it is called ventricular tachycardia, and this is what is life-threatening. Oftentimes physicians miss these early signs, but it's often triggered. You can see it at the bedside if you're kind of paying attention, and oftentimes the alarms may or may not be going off, so pay attention to those alarms. This is Dagoberto. He's the child that has probably taught me the most about how to manage these arrhythmias. He had a total of 3 crises. One included a heart failure that was involved in 2018, and spent nearly 9 months in the hospital. As you can see, this is him. His rhythm begins with some extra beats. If you don't do something quickly, this is us. We rushed him to the intensive care unit. He will develop, this is the abnormal life-threatening rhythm, pretty quickly. It will cause you to pass out. You'll lose consciousness. And if you don't stop it, you just don't get, your heart can't pump the blood. And so this is an example of how it's going. I administered a drug immediately, which immediately terminated the rhythm. The drug that I administered, I put at the bedside. I had it ready. It's not a drug that's typical that you would typically have. So it's important that you have physicians that are aware of TANGO2, what are the options, and some of these unusual drugs that we use to manage it. And they need to be very quick about it. If your EKG, again, shows a QTC that's greater than 450, you have a likely evolving crisis, and again, you should admit. In red is kind of the things that I think you as a parent might be able to do. Make sure your child's on a rhythm monitor, pay attention to the alarms, and alert your doctor if you see abnormalities. Avoid QTC prolonging drugs. So there are actually drugs that physicians can give your child that will make this worse. Some common things like Zofran, which is an anti-nausea medication, Benadryl, Reglan, all medications that can prolong the QT and make this much worse for your child. There is a website called credible-meds.org. You can look at it and check any of the medications that your child's on, particularly during the hospitalization. Magnesium level, I think, can be very helpful. So if you're on rounds, it's probably worth listening to that number. It's important to keep up to prevent arrhythmias during the crises. and the physicians can give magnesium. If you do see any PVCs, I recommend transfer to intensive care unit. I think it's helpful if you have a pediatric electrophysiologist, but we have helped many hospitals around the world deal with these arrhythmias if they reach out. Follow the EKGs and don't discharge until that QTC normalizes. Many time and again, I've seen the QTC, it's still long. The child is sent home, and nutrition may or may not be adequate, and that child just ends up right back in the hospital. ECMO support is a last line resort. It's always important to me to ask if your center has ECMO, because if worst case scenario, if you don't have ECMO, there's not a lot of options if the rhythms become very difficult to control. If the QTC is prolonged, you want an echocardiogram to determine if there are signs of heart failure. And the echocardiogram, if it's normal in the beginning, should be repeated because, for example, in my patient, it was completely normal and didn't develop until midway through. The heart failure can cause high heart rates. It can cause respiratory symptoms, meaning fast breathing, lower oxygen levels, or you might not see any symptoms at all. So it's important that you don't just rely on watching the child without getting that echocardiogram. If there is heart failure, like I mentioned, we want to manage the IV fluid rate, and certain medications may need to be started. This is Dagoberto. After all 3 of his crises, learning a lot, making sure his QTC normalized before we sent him home. We did place a G-tube after the 3rd one, and we've been administering a supplement. We used to give more. Currently, he gets 1 can per night. He's on a multivitamin. He's actually on no other cardiac treatment. He does not have an ICD, and his heart's completely normal, and this is him today. So outpatient management, data is limited, but arrhythmias don't occur when you're well. So that's the good news. If your child's well, if they're not in crisis, you don't have to worry about the heart rhythm or the heart failure. This seems to be something that's really kind of focused around crises. The beta blockers have been prescribed. I personally don't recommend them as a side effect. For one thing, if you don't have rhythm problems except you're in crisis, when you're in crisis, I don't think, in my mind, I don't think it's a good idea to use beta blockers. Beta blockers are a form of medication that are used almost uniformly in children who have prolonged QT. But the problem is that it can cause hypoglycemia or low blood sugars as a side effect, and it can lower the heart rate. In TANGO2, faster heart rates are what are helpful. So having a low heart rate, being more susceptible to hypoglycemia, to me doesn't make sense when there isn't a problem when your child's well. If an ICD is placed, this is more for the physicians. Please, do an atrial lead because pacing can be a treatment method. And if you only place the ICD, which is the general approach, with 1 lead, that doesn't help us. So this is an example of how the natural history study helps us get information. These are 4 different participants, and they're indicated by the blue line, right? Down here are the ages in years. And so the red line represents this person's or this individual's first crisis. So you can see all of the crises kind of occurred around 1 to 2 years of age, the first symptoms. And then these orange bars represent crises. So in this child, they had 3 crises, separate crises, all within the first year. This one kind of later, around age 5. This one only had 1, and this one had 3. And so what we can do is we can begin to build stories and see what does and what doesn't help. In this case, this child was given carnitine and yet continued to develop crises. So in my mind, I see carnitine here, I see carnitine and CoQ10 here. I don't, and the crises still continue. I feel that probably these 2 supplements don't prevent the crises. In this child was given B12 and folate and got much, much better. And the B12 and folate were stopped, had his first crisis, got put on carnitine and CoQ10, continued to have crisis. This is Dagoberto. We ended up putting a G-tube and putting him on supplements at night, and he has gone and not come back in since. He's not had a crisis since. And this child, again, has been given some, potentially some vitamins, has not had a crisis. And this child did get a G-tube, but wasn't getting much through it, was getting Gatorade, continued to have life-threatening crises, ultimately got a G-tube and started using Nutrin which is another supplement, and is now currently in our mid-20s, and has not had a subsequent crisis. So the more of these that I can build, the more timelines, the more that you as parents can remember, the more we can begin to build stories to identify what does and doesn't work. What else can you do? If there's questions, please don't hesitate to reach out and ask us and tell us. Obtain your children's medical records and consider participating with us in the natural history study. Consider keeping a binder or notebook with details, including your hospitalizations, documenting medications, treatments, good days, bad days, anything, and anything that you think is your child unique, whether or not it's unique to your child, may make a difference. Recently, a parent told me that administration of chloral hydrate completely improved their child's symptoms. I have no idea if chloral hydrate has anything to do, but it's on my list. And certainly if you have any experience with it, tell us. This is how we're going to learn, but we really need each other for questions. I've given you my email address. It isn't one, please don't use it for urgent. It's not one that's going to come immediately to me, but you can send me questions. I think teamwork is key. Each of us, physicians, scientists, we need your help as parents to really find the answers for TANGO2. So I'm going to finish with that. Thank you so much.
Thank you so much, Dr. Miyake. This is wonderful, and Dr. Lalani as well. And I would like to now turn it over to Laura Moore, who's speaking, I guess, from her, okay, I can see you now from your husband's computer. Wonderful. Thank you. And go ahead, Laura.
As Susan said, my name is Laura Moore, and thank you so much for having me. I'm going to share with you my experience with our daughter who has TANGO2. And I had a typical pregnancy with her with a long labor, but it was a normal delivery. She was a very happy baby. She slept very well and ate well. But around 6 months, when she started sleeping even better, I felt like she had stopped developing like our other 2 children had. At her 6-month visit, I raised concerns to our pediatrician about her lack of ability to sit supported. And I was told that it could be from being a 3rd child, being held too much, being in a car seat too much, and not to be concerned. But by 9 months, I was adamant with our pediatrician that she was not functioning or developing like our other 2 children had. And we were referred to receive therapy services for her physical and speech through a state program we have here. Reaching almost 2 years old, she still was not developing or thriving. We had taken a family camping trip to the mountains, and she woke up early one morning, and within a couple of hours, she seemed to flop back as she sat on the floor. She seemed to have lost body and eye control, and this looked like seizures to us at first. But as we spoke to her, she seemed as if she could hear us, but couldn't turn or focus, couldn't control her body. It was like she was there, but not completely there. Over an hour of holding her, her function slowly started to return as she took nourishment. With the event, we called the doctor immediately and were told to go to the ER. We traveled 4 hours back home to our ER, and over that time, she was slowly returning to normal after a nap and eating. We were admitted to the hospital where they did an EEG, MRI, and blood work, which all came back normal. This began a 3-year span of multiple MRIs, EEGs, spinal taps, blood work, and specialist appointments. From the time she was 2 till about 4 years old, she would have episodes that looked like alternating torticollis, where she would lose function of half her body, lose eye control, and regress in her abilities with no answers from any medical tests or physicians. Every therapist, physician, and special needs parent I would ask, have you ever seen anything like this before? And everyone answered no. For this reason, we wanted to have genetic testing done. A company was recommended to us to use for a whole exome sequencing test. with hope that we might find something out. The results came back inconclusive. The physician told us we would have one more opportunity to look back at it at a later date to see if something was found then. What people don't tell you about a whole exome sequencing test is that unlike every other medical test run on your child up to that point, the results aren't based on your child. They're based on the information the company has in their database. Over time, her genes wouldn't change, but the information they have to compare them to would. I wish it had been explained to me like that at that point, because it felt like utter hopelessness when someone says, we've done the last possible test and there's no answer. December of 2016, she caught a stomach bug and she seemed to be over it. And within days, her episodes had become nonstop. After contacting our neurologist, he stated that illness must be manifesting and causing her episodes, and to seek medical attention from our local pediatrician. She wasn't found ill, but was considered dehydrated. So we drove her to the hospital 4 hours away where our specialists were. We were seen at the ER and treated for our constipation and dehydration. She was given an enema and a bag of fluid, and we saw improvement. We stayed the night in a hotel near the ER to ensure nothing happened overnight. Even though she was still weak and unable to walk steadily, she seemed to be better the next day. So we went home. As much as she had improved in the first 24 hours, she then digressed much, much more in the next 24 hours. Waking up Christmas morning, unable to even hold her head up, leading us to return to the ER where we had been before. Upon arrival, they thought she was septic and began to manually flush her body with fluids, run labs, and pull urine. Immediately upon pulling the urine, it looked like tea or coffee. And the ER recognized that she could have rhabdomyolysis, and stated that after pulling her labs from the 2 days prior ER visit, that her liver enzymes were even high then. We were admitted to the hospital without an explanation of how or why she could have this. She was very ill and in a lot of pain. And after 3 days of her CK level being above the registered level, they finally tried to count it manually, and it was over 110,000, and they stopped counting. Excuse me. Ellie lost all strength in her body, unable to chew, swallow, or lift any part of her body. I apologize. The hospital genetics immediately said they would take another look at her whole exome, that this was like an anomaly to them, and they couldn't explain it to us. And in the meantime, we had no extra answers to why this was happening to her. After 58 days, almost 2 months of recovery and rehab in the hospital, she came home with extremely high tone in her legs and extremely low tone everywhere else. She had to relearn all the skills she worked so hard for since birth. Excuse me. I prayed this horrific event would lead us to answers, but it didn't. It left more questions instead. April 6th of 2017, we got a call that the whole exome relook was back with an answer, and she had TANGO2 deletion. There were only 2 papers published on it in the recent year, and nothing else was out there. I searched and searched, but I also found nothing. We met with a new geneticist who helped us to track her new concerns and to manage her diet. I wish someone had told me that diseases and genetics vary greatly with each person or case. Please realize that severe symptoms or cases is how change in research would most likely start. And as I look back, I realize this. Just as it did with my daughter, if she had not just had the mild tone and the tilting without the metabolic crisis, she might not have gotten that diagnosis. she would still just be part of the many cases of unknown. Just like I'm sure if a disease didn't have a mortality level or a major effect on body function, research or deeper looking might not occur. I am so grateful to and have mourned for those that have gone before with TANGO2. These are the children and the people who have made a difference in my family's life. The compassion of researchers willing to see and question when these major effects took place has helped with diagnoses. These 2 published papers instilled a deep fear in me that wasn't necessary, a fear of the unknown with very limited information from that very small sample of the studies. What I would have said to anyone now that is given a new diagnosis of a rare disease is to remember that it can have a wide range of normal. You have to take into consideration your sample size, and that even if the study cases seem scary, their extremity is what caused the trigger in research. 9 months after diagnosis, after searching for more information, at one point you search and you find nothing and then you stop because it becomes empty feeling. And then 9 months later, I randomly started searching again. And that very day, we located a few other families through a Facebook group that had been diagnosed with TANGO2. Finding these families led us to trying supplements under our doctor's direction that we feel has transformed her quality of life. Like many other TANGO2 patients, she requires food and nutrition every 2 to 3 hours at most. I prefer 2 hours and a consistent hydration. When she goes longer during the day and there is an activity or stress, she can melt, as I would describe it. It looks like a serious behavior disorder or even a low blood sugar episode. I speculate that's what probably caused the tilting or the loss of body function when she was little, but I didn't know to prevent it. No one knew about TANGO2 or to tell me to try that then. Within a year, one family started the TANGO2 Research Foundation, and my husband and I volunteered to help. There's been a family conference, like Seema talked of, that we attended, where we got to meet these families who understood what we had been through. And the foundation is leading the way in research, and it's now where we go to our doctor appointments and share our knowledge with them. Now, we share information to our physicians. If you're interested in learning more about TANGO2 or would like to donate to the foundation, you can visit the website, tango2research.org. We'll be getting a virtual fundraiser at the end of February that I just would like to share. And I didn't have any information to really share with you on slides, but just our story. And I hope you enjoyed it. But if you'll see on the page here, the TANGO2 Research Foundation has changed our lives. Thank you.
Thank you so much, Laura. I'm sure that many families can feel very similar emotions to what you've expressed, and also for the students and the physicians on this webinar have learned greatly from your experience as well. Thank you very much. I'd like to open this up for questions for all of the speakers, and I know that there are some questions in the chat. And let's see here, there was a question up. I believe some of these questions have been answered throughout, but I think there was a question with regards to some of the children. Let's see if I can find this, that some can walk and play sports and others are much less mobile and require wheelchairs. And do we have any idea of the reason for that right now?
You know, I would say that we don't understand that. Like I showed you the running abilities of some children and severe gait problems in others, and we don't know. We have definitely seen children who've had very serious crises and they've lost abilities to that extent that they're not able to walk independently. But there is just so much more to learn about why there is this difference.
Thank you.
Yeah, I also responded and said that, I worry that even these small spells, what I call these small episodes that Laura talked about, she's able to prevent by frequent feeds. If you, maybe it's a continuing to have those, maybe it's multiple crises and these setbacks, maybe it's your genetics, maybe it's already programmed. These are the things like Seema said, we don't know yet, but certainly these are, the more children we see, the more we'll be able to know. And like you said, there really is a spectrum. There are adults living. There are many children who don't have as many of these symptoms, that don't have the crises. And that's what's going to be very helpful to know. Why don't they? What are you doing differently? What are you taking? And so I think we have a lot to learn, but I think that we could potentially try to find answers to that.
Christina, do you have any thoughts about how children do with COVID, TANGO2, and then about vaccine for them?
Yeah, so I've only had one patient that has had COVID, and they did fine from both a heart and from a crisis standpoint. They never went into crises, but also was having a lot of GI symptoms. So that really concerned me the most, not more because I was worried about them tolerating feeds and food. Through that one, we admitted, we monitored, and we gave nutrition. We actually gave TPN, or parental nutrition, through an IV, and the child did well and never had a problem. A couple points about that case. There were a couple PVCs, and I wasn't sure whether that's something at baseline. So you might see your cardiologist getting something called a Holter monitor. Didn't mention it, but that's kind of a baseline rhythm monitor, just to see what your child does, what type of rhythm they have when they're well. It's really helpful to know what's at baseline, and to know, what the differences are when they come in. Because PVCs don't always mean a problem, but they are definitely a warning sign. Lastly, I want to mention the feeding. Just be careful. Many of you have gone through this. You've seen the drooling, the weakness. That increases your risk of aspiration, meaning that if you're not able to control your swallowing, that can increase your risk. So just be careful during crisis. I know the focus is going to be on feeds, but just be careful about feeding, because your physicians might not realize that it really starts to affect your ability, and you can cause problems just by taking oral intake too. So you want to watch that. Okay. I just didn't mention that in my talk, so I wanted to be careful.
So Christina, I have a few more from the chat. Do you see crisis without a trigger, like spontaneously? And the second is, can exercise be a trigger?
For all of the cases that have come, that have talked to me, I feel like we've always found a trigger. The last one, we were, scratching our heads, I think, trying to figure it out, and it turns out it was the dental abscess. Exercise, I have not seen exercise itself as a trigger, but I do wonder, families tell me, you guys might know this more, but when you are very active, when your child does a lot of activities, they tend to be more affected. They tend to be more tired. So if you combine that, if maybe in the heat, potentially, but I have not seen that yet as a parent coming to me as a trigger.
Mm-hmm. Next is, do any adults or older children have episodic events of skills being lost or ataxia similar to that seen in toddlers?
So I guess for me, for the adults that I've had a chance, it seems like the episodes were more earlier, and it seems like either that adult or the family has recognized the importance of feeds, like whatever. So if you've lived to 29, they figured out kind of what their strategy is. And to me, in the cases, it seems to be honest, feeds. And it seems to be that those adults are they're taking Boost or Ensure or something daily. And so I haven't seen as much of these ataxia episodes, but it's kind of a persistence of the speech problems, of the delays. But we don't have as many adults in our study. So I don't feel like I can answer that, as well.
Yeah. One more question is, are continuous G-tube feeds during the night helpful?
I don't think, for me, and what I've seen, they don't have to be continuous. I think that the ones that are doing G-tubes, at least like for my family, they started at the beginning, they feed one can. If you're really, really sick, this is when the G-tube comes in handy. If you've got a child who really, nothing you can do, you can get them to eat. That's, to me, when the G-tube can be used, because you don't want, as you know, many of your children have problems with constipation that can make their symptoms worse. And if they feed too fast, it can cause vomiting, particularly in crisis. It can be a problem where it's really hard. It seems like the muscle, the motility, the gut motility slows down. So in those situations where I have a child who has a G-tube that I can use, and you're in a crisis, or you're worried about a crisis, you can do a G-tube slowly. So you can slow down the feed, and that might be helpful. But I think for a healthy otherwise child, I don't feel like you need to be hooked up all night.
Yeah. Jamie, your question about puberty, whether it starts earlier or ends earlier, I don't know the answer to this. I have certainly not seen major problems related to that, at least come to my attention. But Christina, if you know, or any parent, if they want to respond, you're welcome to.
Yeah, if parents want to respond. I honestly think, Seema, this has come up more recently with the children, and it's why I want them to be involved in an endocrinologist, because I want them to focus more on that. We have started to ask questions, but again, I don't think we have good answers. I don't feel comfortable that I have enough information to be able to answer that. I do think that in puberty, once puberty hits, there does seem to be more fatigue, some more spells, what I call spells, during like right as puberty is hitting.
For our son, it's definitely an issue. It started about age 12. He was really stable from about, I'd say, age 4, once we had him on CoQ10 carnitine, until about age 12. And then it really looks a lot again like what it was like when he was little. But the fatigue is the same, but it's presenting different because he can speak more about it. But he would be, and I believe, Ryan, we've compared notes a little bit with Kasha and I could pick him up from school at noon and he would just be flat out almost asleep on the car seat, and couldn't really even keep his body up. So we've just continually had to increase his CoQ10 carnitine and B vitamin supplementation. He takes quite a bit, and for him, it's something that does help. But I know for all kids, it's, the reaction for everybody is different. So, but he's at 15 now, and he just grew more than 4 inches over the last 6-7 months. And it's really impacting him when he's in school as well, from a cognitive standpoint. So he misses school from fatigue, just because he can't get out of bed initially for the day. So that's been our experience.
Christina, I have one more question. Why do crises induce cardiac arrhythmias?
We've had a lot of different potential theories based on the type of rhythms that I've seen. It looks like all of the heart channels, so these particular ions, or their specific proteins in the heart that are important for how sodium and potassium and calcium enter and exit the heart. At least what I can tell you is they all seem to be a bit affected, not just one in particular. So we have focused on the potential that it's a problem. It's not that the children can't produce the heart. So meaning in the healthy state, they can produce all the heart proteins that are necessary for the heart to work. But when they're in crisis, when there's stress, for some reason, either they're not making the correct protein or they're making the correct protein, which is what I think, maybe they can't get it to the right spot in the heart. The heart is continuously cycling these proteins to the different areas they need to go to. So it's called trafficking. One of the theories is that there's a problem getting those proteins to the right location. Another is, again, that there's a problem actually creating the protein. It could be that there's something with the metabolic stress, meaning that there's not enough energy source in order to get things to effectively work. ATP, is a source of energy in the heart. It's very important, and stress may affect that. So we have all these potential theories. Dr. Lalani, Dr. Zhang, who is a basic scientist, a geneticist, and a cardiac specialist in the lab, and two other physicians. We're all working on this actually as our project. We're trying to look at the heart, and we have, thanks to you as parents, we're actually using the heart cells that we created from a child with TANGO2. And we've created those heart cells, and Dr. Zhang's doing an amazing job so we can actually take the heart cells in a Petri dish and test it without testing or hurting your children. And so that's exactly what Dr. Zhang and Dr. Leon and all of us are focusing on. What's the mechanism? What can we do to start looking at that? That's a big process. It's a lot of work, but want you guys to all know that we are at least thinking about it. We have ideas in mind. But like I said, in science, or as physicians, evidence is really what we need. We don't want to say anything without knowing something, and that's really where it comes, where we have to put it to the test.
Thank you so much. Dr. Lalani, Dr. Miyake, this has been an outstanding evening, and I really thank each of you for your time, your presentations, and for all of these incredible questions. I think we could spend the rest of the evening with you all. This is really a wonderful environment to be able to do this with people around the world. So I just want to thank you for the major effort that you all have made to give these presentations. And we put a survey link in the chat. Thank you, Laura Ellis. That really does help us in planning future seminars and learning your feedback from this seminar. And we greatly appreciate you taking 2 minutes. It's just 10 questions. And just want to let you all know that on January 26th, our next webinar will be on the topic of direct-to-consumer testing, what you may want to know about. And the February topics are going to be on race and genetics, and we're going to have 2 dates devoted to that topic with 6 speakers. So I am profoundly grateful to Dr. Lalani, Dr. Miyake, and Laura Moore for your presentations today. And thank you all, and have a good evening.
Thank you, Susan. Thank you all.
Thank you. Bye-bye. There's a little one.